This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 610, recorded on May 5th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Austin, Texas, Rich Condit.
Hello, Vincent. Here we are in Austin, Texas, 73 degrees and cloudy. I would like it to rain. It would like to rain, but it doesn't appear to be happening. That's where we're at.
From southeastern Michigan, Kathy Spindler.
Hi, everybody. It's about 50 here, and it's kind of gray. Partly sunny, partly cloudy.
And from Madison, New Jersey, Brianne Barker.
Hey, it's great to talk to y'all. It's 59 here, and it's pretty gray as well.
Y'all, you got a little of that southern residue, don't you?
I do. I spent just enough time in North Carolina to find that a very useful word.
Yeah. Well, on the weekend it was warm, and then all of a sudden it got chilly yesterday and today here in New Jersey anyway, right?
Mm-hmm.
You find that, Brianne? Yeah.
I did. And of course, everyone was very excited to try to go outside when it was so warm. I ended up getting attacked by the pollen, but everyone else liked it being nice.
I had to grade my exams, which I did. I finished them all. I finally finished them.
Just a midterm, or have you given the final yet?
No, it's just a midterm. I've been weeks grading them. I feel really badly, but now next Monday is the final. So, but I'm going to have help from Brianne and Kathy on my exam questions and make it easier to grade. Not in grading them, but they gave me some questions that'll be machine gradable.
Yes, I gave my final this morning, and I will send you some questions now that I'm done writing it. All I have left is grading.
Yeah, yesterday was my last lecture. It was very sad. I'm always sad on the last lecture because I enjoy it, and it's nice to see all those students. Mm-hmm. But this time I didn't see them. It's funny, even on Zoom, they don't even have their video on, so it's just their names.
Yeah.
They don't talk. They just type in chats, But it's a different world. If you enjoy what we do here on TWiV and all our other podcasts, please consider supporting us. It's our only means of support from you, our listeners, and two important science societies, which you'll hear about later. Microbe.tv/contribute. So today we're going to try and tackle some email. You all send in great email, by the way. And, we'll probably not get to every one of them, but we'll try and do a lot. And but before we do that, a couple of little things to keep you up on the situation. Now, everyone is hearing about antibody tests, which I don't know. Have we talked about antibody tests on TWiV yet? I guess we have.
Yeah, we have.
Oh, of course. And of course, Jeff Shaman talked about them a lot. Mm-hmm. So you know what they are. But the FDA has revised their policy on antibody tests. They had already said, back in March, we need to be flexible, more flexible than the PCR tests. So we're going to let these be out there sooner than we would. We relaxed some of our standards, but apparently that's not working out well because not all the tests are that good. And they said 12 antibody tests have been authorized, and you need a EUA for these to make critical products, right? Emergency Use Authorization. So they've done 12, and 200 are under review.
Whew.
So they've revised their policy that, first of all, you have to submit your EUA requests within 10 days from when you notify the FDA of their testing. All right, that's one. And then the FDA has provided performance threshold recommendations for specificity and sensitivity. So that's new because before they weren't. And there were a lot of stories of tests that weren't, they're not 100%, they're not 90%, which is not good because a few percent can make a big difference.
This weekend, John Oliver actually did a whole segment on antibody tests, and it was wonderful.
Now, wait, John Oliver is a comedian, right?
He is a comedian.
But he does a good job.
He does a great show on Sunday nights on HBO of the news, and he goes into detail about things. And his discussion of antibody tests was fantastic this week.
No, he was serious about it. He didn't make jokes.
No, there are always some jokes sort of in the side, but he was really covering what's going on with antibody tests and the issues with sort of the Wild West of antibody tests that had been going on.
Good. He must have staff working for him, right?
I think so.
Well, here on TWiV, we are our own staff, by the way. We don't have any staff.
So because of a letter that is coming up, I did a search to find out, see if I could find a list of the approved serology tests.
Yeah.
And I came across a really nice site from Johns Hopkins. It's in their Center for Health Security. And it's a page or a series of pages called Serology-Based Tests for COVID-19. And it has a lot of information on this, including one of the sub links is tests that have been approved for diagnostic use in the United States. And this, I don't know how up to date this is, but of the tests that are approved for diagnostic use in the United States, there are 7, according to this list. 2 of which are the lateral flow assay that we've talked about. That's the rapid test. And those come from CellX, which we've already discussed. And the other is from Auto Biodiagnostics, jointly with Hardy Diagnostics. But this has links to other categories as well. It has a description of types of tests that have been approved for diagnostic use in other countries, tests that have been approved for research or surveillance purposes only, tests that are still in development. So this looks like a pretty rich resource on serology testing.
And the approval that you mentioned is that EUA approval. So
I don't know that for sure. I haven't looked into this site in detail, so I can't verify that. I would assume so.
I'm looking at it now, and where it says approved, it's approved for EUA by the FDA. Okay. And at the beginning, it has a really nice table, as you said, describing rapid diagnostic test, Iliza tests, neutralization assays, chemiluminescent assays, the time, what they tell you, and what they cannot tell you. So it's
very good
site. Yeah,
it's a nice resource.
Let's have figures too of each one. Very nice, very nice figures.
I'll remember for next time I teach virology.
Here's a question. Maybe I should put this on the exam, but they're not going to listen, so I can tell you guys.
If they do listen, that's a bonus. They get some points on the exam.
Okay, so we've developed this is a question. We have developed a assay for neutralizing antibodies, but we can't work with SARS-CoV-2. What can we do to measure neutralizing antibodies?
Do you want an answer?
Yeah, you guys have an answer. Go for it.
I got an answer. I would make some sort of pseudotyped virus.
Yeah.
I don't know what that's going to be because I've got to basically put a SARS envelope on some other kind of genome. I mean, typically they do this with like VSV or something like that, but I don't know if that's going to work in this case. I don't know what I would use for a virus backbone to pseudotype, but that's where I would be aiming my attention.
What were you going to say, Brianne?
I was going to say the same thing, and I was even going to put it on VSV because of the experience with the Ebola vaccine.
Yeah, and that's exactly what people have done in Theodora Hatzianu and Paul Binash have developed one, and they're using it to validate some of these antibody tests, actually. So she's very excited. She said she's in the lab all the time because she's one of the few people who can do the assay.
And for the listeners out there, pseudotype just means you take some virus and stick somehow modify it so that it's using another virus surface viral attachment proteins and et cetera. So it would attach to and invade cells as if it were SARS-CoV-2, but in fact, the virus itself is something else like VSV, which is harmless, but you can still assay it with a plaque assay or something like that.
In fact, when they were going to get some of Ian Lipkin's blood to check it because he recovered, right?
Oh, wow.
And they wanted to check. Let's check for neutralizing. So you're looking specifically for antibodies that block infection, which we call neutralizing antibodies, right? And of course, you're not going to just see antibodies that will bind but don't neutralize. Some of them may be important, right? So neutralization isn't all that it's all about, but it's a big part of it. That's a good question, don't you think?
It is a good question. It is a good question.
They should know the answer. And if they listen to TWiV and get it, power to them, right? This is a really good site. They have here the specificity and sensitivity for some of them. And I'm looking at the Mount Sinai Iliza test, which I think we mentioned a while ago from Florian Kramer's group there. And I didn't realize this test detects qualitatively IgG present in serum. It's an ELISA-based method, uses a 1:50 dilution of human serum that's flowed over a plate coated with the spike protein receptor binding domain. That's very interesting. So we were talking about this, remember, that you could try and sort of gear it to antibodies that are neutralizing by just putting the RBD there. Although I think, Brianne, you mentioned that some antibodies will still not be blocking attachment, right?
Yes,
depending
exactly.
on how they bind to the RBD.
You could have some antibodies that are non-neutralizing, and you could also miss some of the neutralizing antibodies.
Even with the RBD, right?
Even with the RBD.
Got it.
It's interesting that something is strictly qualitative, so it probably gives them a plus or minus result.
Yeah.
Is approved by the FDA. I suppose, basically according to some standard that something is or isn't positive, you would think they'd say it's accurate a certain percentage of the time. I don't know.
Yeah, they say the specificity and sensitivity is in progress. They don't know. They can do that, right?
But still approved.
Yeah. Well, quite a few of these don't have EUA. Yeah. That's a cool site. Very good. Now, in connection with this, I have an article where it's an announcement that Roche's test has been approved or authorized by the FDA. It's 100% accurate at detecting coronavirus antibodies and 99.8% accurate at ruling out the presence of those antibodies, which means, very few false positives, or maybe more accurate. What would be a better way? Fewer false positives. Yep.
Right.
So both fewer false positives and fewer false negatives. So Roche.
Yeah, this one also EUA type approval.
And here's an interesting point. Though the differences in accuracy, and they compare to some other companies, Cellex 93.8 at detecting antibodies. That's sensitivity. 95.6 accurate at ruling out the presence of antibodies, which is specificity. Another company is 80% sensitivity and 99.5 specificity. So they say, and this is really good, though the differences in accuracy may seem small, our simulation, this is Quartz, it's the name of the website, shows they have huge implications when only a small proportion of people are infected, as the number of false positives can easily equal the number of true positives. For example, if 5% of 1,000 people have had coronavirus, then using the Cellex test, a positive result stands only a 49.5% chance of being correct. Using the Roche test on the same population means a positive is 96% likely to be correct.
This is most important when you're looking at a population where a small proportion of people are infected.
Right. Which is a lot of places, right?
Right. So this is sort of the positive predictive value that people talk about in epidemiology.
So that the Roche test does not show up on the list of approved tests, which to me means that the Johns Hopkins website is not up to date. Byte. I mean, this article about the Roche test is May 3rd, 2 days ago.
Right.
So it's not completely up to date. There is a Roche test mentioned as under development. I don't know if it's the same test as this or not. They don't really say anything about this test in this article. The test listed on the Johns Hopkins site is an Iliza.
All right, one more thing from me. This is a trio of articles in the New England Journal all about ACE inhibitors and angiotensin receptor blockers, ARBs, which a lot of people take. There was some concern whether these were linked to disease severity, and they're not. So, for example, one report called Cardiovascular Disease, Drug Therapy, and Mortality in COVID-19. Conclusion, our study confirmed previous observations suggesting that underlying cardiovascular disease is associated with an increased risk of in-hospital deaths among patients with COVID-19. Our results did not confirm previous concerns regarding a potential harmful association of ACE inhibitors or ARBs with in-hospital death in this clinical context. Many people take ACE inhibitors for blood pressure, right?
Mm-hmm.
Yes, and they've been very worried about whether they should keep taking them because it might change their receptor for this virus.
And then there's another one by different authors, renin, angiotensin, aldosterone system blockers, and the risk of COVID-19. No evidence that ACE inhibitors or ARBs affected the risk of COVID-19. So they say, this population of COVID-19, they have a higher fraction of people with cardiovascular disease, and they're taking these drugs. So those three studies are very good. And then there's a commentary associated with it. We get a lot of questions about this, I think. So
yeah, the commentary is very good. It gives some detail on the individual studies and summarizes them. It's well done.
I think this is a nice sort of piece of news for people who have been really worried about this. Hopefully this can make them feel a bit better about staying on their medications, which of course Daniel had mentioned they should do.
Mm-hmm. So we can call all those questions from the email. It'll take about
Right.
10% of the questions out. Okay, Rich, what do you got here?
Okay, so I'm obsessed with this modeling site, the Institute for Health Metrics and Evaluation, that we've talked about before. And I want to preface this by using the old quote, all models are wrong, but some are useful. So this is just a model, but it's often accessed in the media. A lot of people use it. And just to remind you, it was developed out of the University of Washington, and it was developed in response to people trying to figure out whether the hospital capacity would be adequate under various conditions to handle the disease. But then it's been extended out to contain lots of other metrics as well. And they've done a major revision of their modeling recently, and I've heard about that in the news. And they've added a lot of stuff into it, and there's a description of what they've done. So at any rate, it now projects that by August 4th, it's not clear to me whether they're projecting that the current level of social distancing will continue as is, because they can't really predict what modifications in behavior there might be. And they do this model does include what social distancing measures have been announced by different states and et cetera. So it includes some of that, and I don't think they can actually project it. But I think given the current conditions, they project that by August 4th, deaths in the U.S. will have leveled off at 134,000. And I'm obsessed enough about this so that I went through them state by state to look and see what their assessment of the hospital capacity was now. Because I think one of the things we're struggling with as a nation is that I personally don't think that managing this is a one-size-fits-all problem. Certainly in the beginning, when we didn't know what to expect, we didn't know anything about it, sort of locking down globally made perfect sense to me. I don't think mistakes were made. People talk about overreacting and stuff. No, we didn't know what was going on. Now we know a lot more, and we don't know enough because there's not enough testing. But there's a lot more data state by state. And I think it's not unreasonable to say that it's not a one-size-fits-all situation. And out of curiosity about that point, I went through this site and scored state by state which states, according to this site, as of today, had sufficient either all beds in the hospital or ICU beds, intensive care unit beds, and which were at this date, regardless of what's going on before, which were deficient. And what I came up with is that
at this date, I'm sorry. When you said at this date, do you mean August 4th or do you mean today?
Today.
Okay.
Today. And today is what? Today is May 5, Cinco de Mayo. Okay. And what I came up with, because by August 4th, I think probably if you looked out there, if you looked out there, I think everybody's under control. By the way, the curves that are modeled in the more recent model has they don't bottom out as soon. It's drawn out longer than we saw in the previous models, the whole pandemic. So at any rate, what I found was 11 states plus the District of Columbia are short of ICU beds. According to this, I don't know that that's their real experience, but according to this modeling, they would be short of ICU beds on this date. And those were Connecticut, New Jersey, District of Columbia, Delaware, Georgia, Indiana, Maryland, Massachusetts, Michigan, New York, Pennsylvania, and Rhode Island. And there was one state that was just barely sufficient in ICU beds, and that was Illinois, I believe. In addition, there are two states, Connecticut and New Jersey, that in fact are in a deficit, according to this, in all beds. And my guess is that has to do with proximity to New York, but that's just a guess. So this, basically my bottom line from this is that I said, not all states are created equal in terms of their experience of this. I mean, that should be obvious, but this really makes the point to me. I wanted to add one other thing, and this is just me, okay? This is my simple-minded calculation, because everybody, when they talk about social distancing and its impact on the number of deaths and all that kind of stuff, I feel like there's this sort of assumption that when you impose a certain amount of social distancing and the curve starts to, the daily cases start to bottom out, that the virus is gone. Now, they do talk about, if you lift the social distancing, there's going to be a resurgence and that kind of stuff. But I still feel like it's not taking into account the ultimate situation. And to me, the ultimate situation, as we discussed with Ralph Barrick earlier, once again, this is a model, these are assumptions, but we've talked about this with several experts on the show, is that at equilibrium, and this may be 2, 3, 5 years from now, I don't know, 80% of the population will be seropositive. This is a model. If that's the case, and given that the best estimates now that I can find from the Center for Evidence-Based Medicine at Oxford University is that the infection fatality rate is somewhere between 0.1 and 0.4%. That means that ultimately you're talking about between 250,000 and 1 million deaths in the United States. And it's not, so to me, it's a matter of managing this appropriately so that the healthcare system is not overwhelmed and the people who are going to get sick get absolutely the best care possible, and that people who are not even sick from COVID-19 are also getting the best care possible. But ultimately, I don't see any way around, if the assumption is correct that there's going to be 80% of the population that's been infected and ultimately winds up seropositive, and infection fatality rate of 0.1 to 0.4%, I don't see any way around ultimately the number of 250,000 to 1 million deaths in the U.S.
Unless something shows up that can save lives, right?
A drug or a vaccine would change that dynamic, yes.
Yeah.
One thing with respect to Michigan's numbers is I'm on a site that's current as of May 3rd, And I'll put the link in, but basically looking at ICU bed availability for a bunch of regions across the state, there's more beds available than are occupied. So that statistic may not be as bad as what you found on the other site.
Let me look at the other site, because some of these were just barely in trouble. Michigan, according to this, had a deficit of ICU beds that has had a deficit of ICU beds. See, I don't know how real these numbers are, right? This is a model that is on its way down. And they're talking about, they think that there are 743 ICU beds available. And according to them, you would need just short of 1,200 ICU beds. So
I have a statewide available bed tracking. ICU beds 3,300, beds occupied about 2,100.
Wow, so that's significantly different than this site.
Yep.
Interesting. Okay. All models are wrong. Some are useful.
Also, when you say like New York is in a deficit, depends where you are. Also, that's overall. Yep. But certainly, if you go upstate, there are more hospital beds. Cindy Leifer said last time that hospitals in Ithaca are fine. They hardly have any patients. And Nell said even in Salt Lake City, the hospitals are empty. So it really depends.
Right. Yeah. And this Michigan one is, I was going to say, this Michigan one is broken down by all these regions, and there's no region in which there's a deficit of ICU beds.
Okay. Very interesting. Okay. So my point is primarily that there is regional variability in all these numbers. And that's why the testing and the contact tracing and all that kind of stuff is so important, so that you get an accurate status on an accurate reading on what the status of disease is in any particular area, so that then you can make appropriate recommendations for how the population should behave.
Yeah, I'm looking at this Michigan site, Kathy. You know what I'm looking for? I'm looking for Lansing, but it's not. They don't have a hospital system.
So they have. It's by region, and so you have to know the county names. And I'm looking at that list of county names, and that would be Region 1. It's in Region 1.
Because there's a famous polio strain, Lansing, that we used to work on. Which we can no longer, because it's type 2 and it's been eradicated, and you have to have destroyed all your type 2 stocks.
Right.
One email here is related to antibody testing from Kyle, who listened to TWiV for the first time and doesn't have science backing, but he's naturally curious. And he asked a question about antibody testing. He lives in Michigan, where a local urgent care advertised rapid lateral flow immunoassay antibody testing by appointment. He called, made an appointment, and he was IgM positive and IgG negative. And the doc said, it's not FDA approved, so I can't speak to its efficacy or accuracy, but I'd advise self-isolation, and Kyle has no symptoms. So
he said he was sick, and did you already say this? He was sick in early February?
Yeah, that's right.
And had all the symptoms?
Yeah, but IgM wouldn't necessarily make sense, right?
No.
Should have some IgG.
By now, he should be IgG positive.
And I don't know about self-isolation at this point, right?
No, I mean, I don't,
Well, the state is still under a stay-at-home order, so he should just stay at home anyway.
Oh, it is? Okay.
He asked whether, he says the test was from Alpha Scientific Designs.
Yeah, is that on your list?
No, it's not on the list. That's what prompted me to look for a list.
Yeah, I've never heard of them.
But it's entirely possible that the test result is wrong, based on what we've been saying, right? Maybe it's a false IgM positive.
Yep.
And a false IgG negative all at once.
Yep.
Which is not unheard of, Kyle. That's how it happens. Okay. Kathy, can you take the next one?
Sure.
Email, yeah.
Yeah. Margaret writes, TWiV, dear TWiV, thank you. You're the soundtrack to my life for the past 6 weeks. early on in this COVID horror, in the second week of March, I went looking for someone who actually knew something. I needed to hear people who knew what they didn't know, people with humility and perspective. Then I found you, your perfection. I think of Vincent as the grumpy virologist. I have a whole backstory for you, Vincent. You are prickly yet capable of self-reflection and easily wounded. Your backstory involves some sort of scarring interaction with one or more haughty and self-important immunologists. Oh, my.
Oh, this is a great letter.
There are lots of haughty and self-important immunologists, so that seems possible.
You are on a Parthenon-worthy pedestal, so just stay there. You have kept me sane. I'm so grateful. Thank you to Kathy, the voice of reason spindler. I'm going to try to get my son to consider you, Mish, for medical school. Thank you, Alan, the even grumpier and more sensitive Dove, and Rich, the science translator Condit. And thank you to Daniel Griffin, whose heart-wrenching parking lot stories have left me in tears. Very few will get care from someone like you, but at least the knowledge is out there. At least evidence-based medicine is within our grasp, if only we had a system to support it. You are beautiful people.
Read it.
You are beautiful people. You are the best our society has to offer. You stand fast for science, humanity, and reason, and you are educators. I've learned so much and know even more about what I don't know. I love you, Margaret.
Professor of English. It's really nice.
I think that's one of the most beautiful letters we've ever had. It's just,
Thank you, Margaret.
Just awesome.
Yeah.
It's very nice. I love it. Yeah, we appreciate it. I'm sorry I'm grumpy. It's just, you know what? I was thinking of this. Go ahead.
She's really got you nailed. I love the notion that you've been abused by an immunologist.
Yeah, an immunologist. It's possible, yeah. It's very possible. I am easily wounded. It's true. But you know, this grumpy part, I am never grumpy to my students, the ones in class, right? Mm-hmm. Because if you want to teach people, you shouldn't be grumpy to them because it impairs teaching. Mm-hmm. I know from experience because I've had grumpy teachers in the past and I don't like learning from them. But here on TWiV, I'm grumpy because that's the whole point of TWiV is just to be yourself. You know? Does that make sense?
Whether you are grumpy, science translator, or the voice of reason.
Yeah, indeed. Brian, can you take the next?
Sure, Ellen's.
Yeah.
Ellen writes, Dear Professor Racaniello and company, I'm not a virologist. I'm a speech-language pathologist working in a small hospital in San Francisco. I wanted to say that your podcast is the one thing that has kept me sane throughout this pandemic. Thanks for the rational thinking and the questioning attitude that makes good science.
I thought I would just put two just complimentary emails. I know they're all start out, but these two just have compliments and no questions. Just, we need some feel good, right? Mm-hmm. Rich, can you take the next?
Angela writes, Dear TWiV team, my name is Angela and I am just a virology student in Professor Racaniello's class this semester. Just doesn't apply, Angela.
Well, she's joking.
I think earlier.
I think she's joking.
I read this New York Times article, linked below, written by the president of Brown University about how opening colleges in the fall should be one of the top priorities for financial and education purposes. She details the steps needed to reopen universities, testing everyone, no parties, etc. But I am hesitant to agree with her. Am I wrong in believing that until herd immunity is achieved, college campuses should not reopen? Thank you, everyone, for all you do. Appreciate the time, work, and dedication put into these podcasts. Would you all ever consider doing a live group Zoom podcast so that listeners can tune in all at the same time? It would be enjoyable to see you all in action.
Grumpy us.
And she puts in a link to the Times article, which I have not looked at.
But I think we should do a Zoom. That's a great idea. Let's do it. Open Zoom.
That would be really fun.
What do you think about opening in the fall? Some are saying we're going to open and others say we're not going to open till January. So
this goes back to my bit about basically suck it up. I'm not saying that we should be like Sweden and do nothing. And just say, okay, a certain number of people are going to die, so just let's get it over with. I'm not saying that. From everything that we've done on this podcast, it seems to me that what we need to do is adopt behaviors that allow us to cope with this in a fashion that leaves the healthcare system capable of giving people the best possible care, while at the same time not, trashing our society. And I don't have exactly what that Goldilocks place is, but man, I can't imagine not opening schools in the fall. I think you got to. And I think by the time fall comes around, we'll have a much better understanding of this. There will not be herd immunity established by then. That's probably not for another year. We're not going to, I just can't imagine having schools closed for another year. So, and schools are really important. I mean, because in terms of the transmission of the disease, because that's where a bunch of potentially susceptible people get together all day long and then go circulate out in society. So I have to think that I haven't read this article, so I don't know what it involves, but some sort of not necessarily social distancing, but there could be a lot of hand washing and face masks. And I've heard things about certainly testing, and I've heard things about maybe going to school every other day. That doesn't make so much sense to me. We don't, I've heard school buses half full. Well, we don't have hardly the funds to even run the school buses full. Okay. So there are a lot of issues to be addressed here, but I think, boy, it's hard for me to imagine not reopening schools. And so, go ahead.
What's Drew going to do? Do you know?
Drew has not said. We don't know what Drew's going to do. But I certainly worry about if schools don't reopen. So, I think about the fact that we're having all of these difficulties with our healthcare system. And one of the things that's going to be really important is that we, train and educate new nurses so that we keep, having more healthcare professionals. And if we, close down various universities, then what's going to happen with our supply of all of the healthcare professionals? And if we don't necessarily train some of those people in person, that could be a real problem for their training. And so I think that we do need to think really carefully about this. And there are some important reasons to have universities open, but we need to figure out what the best precautions might be.
Yeah.
So I think, in some ways, Rich may have been addressing the K through 12 issue, at least in terms of schools. But this article from the president of Brown is about universities. And I know that Michigan is hoping to have some kind of in-person classes, but also is preparing for maybe a lot more things online. And I already know of one of my classes that's scheduled for a room that's going to be 3 times larger than the current room that it's scheduled in, for example. So that kind of thing. But even within the state of Michigan, I've heard that Michigan State and Wayne State are not thinking about in-person things at all. And that may change also. To address what Brianne mentioned about nursing, it's also true from the clinical perspective. So
exactly.
Ori mentioned that the medical students, have not been on the wards. There's a person in my lab who's doing nursing training, and her clinical time was cut. And then for this semester, and then she's supposed to start having much more clinical time starting in the fall semester. And we're going to start losing out on those trainees really quickly if we can't have some kind of way to get these people back in training.
Yeah, I agree with all of this. You have to come back, but you have to have a plan. I agree with testing. I agree with smaller classrooms, and I know that a lot of universities, you can't just say split up a class into 5 sections. You don't have the classrooms. Well, then maybe you have to alternate. One day, a quarter of the class is actually there and the others are on Zoom, and then you alternate back. I mean, you have to have some solutions because I think you need to go back at some point, and otherwise the damage is going to be more in the end. So I know our medical center is opening May 18th. they've decided that everyone can come back. But I don't think everyone should come back all at once. I think it should be staged.
Right.
Yeah.
But I do think testing should be really extensive. And, as soon as someone's positive, you quarantine them, you look at their contacts. You can really, that's what Shaman said South Korea did. And that's how they limited the spread. So we should consider that now, even though we didn't do it way back in January like we should have.
Testing and retesting.
Testing and retesting.
Yeah, and that's an important point. I see there's a lot of coverage in the news that has to do with shoulda, coulda, woulda. We should have done this, we should have done that, and pointing fingers to blame people. I think that's all just pointless. Here we are. I mean, we've been learning the whole way. I mean, I know I got it wrong in the beginning. Okay. I didn't think that this was going to become a pandemic. And I'm on record. Go back to TWiV 184 or 185, right? And I was just as slow to wake up as a lot of others. But at this point, that's irrelevant. We've learned a lot and we're here. Okay. Let's move forward. And blame is irrelevant. What we did in the past is relevant only in that we can learn something.
Some guy interviewing me this morning said, "Is it productive to blame China?" I said, "It's never productive to blame anyone. We got to deal with it." Exactly what you said.
I think we have a lot to learn from China. I tell people, well, they're about 2 months ahead of us. Let's find out,
Yeah, for sure.
If there's going to be only short-term immunity to this virus, we'll find it out first because of China. So
It's amazing that they only had 80,000 some cases, right? With all the population. Remarkable.
Yeah.
All right. Thank you, Angela. That was very interesting. We'll do a Zoom. All right. Jamie writes, you are my only source for reliable information, even if your discussion often goes way over my head. All right. Question. My family lives on a rural road in northern Westchester County where a neighbor strangely keeps exotic animals, including monkeys and camels. Given that dromedary camels are known reservoirs of MERS and an important source of human infection elsewhere, would it make sense that they are at risk of being reservoirs for SARS-CoV-2 and holding them in captivity near a human population is risky? We seem to know little about viral cross-species transmission and recombination, and in the U.S. have undertaken little or no captive camel or bat testing thus far. Definitely someone listening to TWiV. Isn't being a reservoir quite different than testing positive? Like the tiger you spoke about in April. Until we know more, should captive camels, along with captive civets and bats, be quarantined in America? Interesting. Well, there's no evidence that camels can be infected with SARS-CoV-2. But they might be, and I'm sure in some zoo somewhere, people are looking. So I don't know until they're, even with the cats that got infected, it was a one-off thing apparently. And a reservoir, yes, is quite different. Reservoir, you have an established population of that species that's infected with virus and can transmit it to other species. And so it's not the case for cats yet that we know of. We've heard a few examples, but nothing more. So if they were a reservoir, we'd be hearing, and we're not. So I'm assuming up till now, they're not. And I would say camels, civets in the U.S., I don't think we need to quarantine them until we have some information on this, right? These animals would all be mostly in zoos, except for your strange neighbor, I guess.
My recollection from when we were covering MERS a while ago, correct me if I'm wrong, but I seem to recall that a global survey of camels showed some populations were seronegative, whole populations, like on the Canary Islands or something like that. And some populations, like in the Middle East, were seropositive. So it's not like all camels carry MERS. There are some populations of camels that do and some don't. I would also imagine that if camels were really going to be a true reservoir for the virus, as you pointed out, you're talking about a population-based thing. It means that there's a bunch of camels that are passing the virus around. And I don't see that sort of population density of camels in the U.S. as being a reservoir that's going to be a long-term issue.
That's what I was wondering too.
Camels in parts of Africa, Arabian Peninsula, also other parts of Asia are positive. But there are only the dromedaries, right? One hump. So there's quite a swath of camels that are infected, but there's no evidence for it elsewhere. It's not in the U.S. So all right. So there's no evidence that SARS-CoV-2 can infect camels. I don't know about civets. Someone has probably looked in civets to see if they're infected in China, but I think to leave them alone for now.
It's not crazy, however, to be thinking about the possibility of spillback from humans into some other animal reservoir.
Yeah, that's why I put this in, because I thought it was an interesting idea.
Ralph Barrick mentioned that in one of the previous episodes, and it stuck with me for a really long time after that conversation.
Yeah. Yeah, he said it might spill back into some other animal, make a reservoir. Yeah. Okay, Kathy, can you take the next one?
Sure. Trish writes, "Hi, TWivers. Is this hashtag fake news? Should I wash this down with a big dose of bleach or a tremendous light? Thanks, Trish. 12C and not gardening weather yet."
Okay, so she links to an article in a publication called RFI. It's a French publication of some sort. I don't know what its sort of credibility is. And the headline on the article is, "French coronavirus strain may be local and may not have come from China." And says, this impacts on this whole idea of blaming China for everything. And what I do appreciate is that they actually reference the article itself so that you can download the article, which I did, which is entitled "Introductions and Early Spread of SARS-CoV-2 in France," with a bunch of authors on it. I'm not going to go through this in detail. It's not like we're discussing this paper. At any rate, I did not look at it in detail, but I read the abstract. And it's a phylogenetic analysis of strains in France. I read the abstract and I read most of the discussion. And interestingly, nowhere in the paper do they say that their work says that there are French strains that may not have come from China.
Exactly.
So I think that is a journalistic spin on this.
Totally.
That's trying to do what we were talking about earlier, and will come to later, of trying to make journalistic capital out of this, when in fact that's not in the paper.
Nope.
The paper is just a straightforward phylogenetic analysis of the virus in France. So yes, I would put that down as fake news.
No, I mean, the sub-headline is, may not have originated in China, is total BS. There are no SARS-like coronaviruses in bats in France, by definition. They only are in China. But the other sub-headline, "The French strain may have been circulating before the global outbreak accelerated." Yes, that's what the paper concludes, that the virus has been there for a while, and it's not a surprise at all. It was seeded from China for sure. So I totally agree. This is hashtag fake news. And don't drink bleach or swallow a lot.
Yeah, please don't drink bleach.
Brianne, you're next.
Sure. Hello all. I'd like to remain anonymous, please. You mentioned whether anyone has looked at rodent coronaviruses on the last TWiV. I just wanted to point you toward these two papers from a lab group at Nottingham University in the UK. And so Anonymous gives us two links to different papers. I believe they are both from viruses. And
viruses.
The journal Viruses, yes, that talk about, one is about shared common ancestry of rodent alpha coronaviruses sampled globally, and the other is about discovery and prevalence of divergent RNA viruses in European field voles and rabbits. So this is sort of interesting, although this is alpha coronaviruses, and SARS-CoV-2 is a beta coronavirus. So they're slightly different viruses, but these do give some information about the coronaviruses that exist in rodents.
Yeah, we had asked Susan Weiss last week about rodent sampling for coves, and she didn't know. So this is in answer to that. So yeah, The phylogenetic pattern of the alpha coves was suggestive of relatively frequent host jumping among different rodent species. I just love the bank vole. I think I have this picture of a vole all dressed up with a lot of money.
Pinstripes.
Pinstripes. And then we have the field vole who doesn't have a lot of money.
Straw hat.
Straw hat. Yes, thank you. That's great. Discovering prevalence of divergent RNA. Yeah, European field voles and rabbits. This is great. This is the kind of wildlife surveillance that we need more of. What years are these? 2019, pretty recent.
Yeah, we need lots more of things like that.
Rich, you're next.
Sean writes, hello. Since January 2020, I have wondered if the novel coronavirus could have been seeded into North America via the jet stream. I am a weather junkie and have observed that the jet stream meanders fairly directly from China to North America, specifically Western BC to Washington State. Can you answer this question for me? My answer, based on just, general sort of knowledge and hunch, is no. Actually, viruses do circulate in the atmosphere. Haven't we discovered some of that before? But I think it's much more likely, and in fact traceable in some cases, that this has to do with human-mediated travel, airlines, etc.
Yeah. We did a paper, I think, or at least I blogged about it a long time ago, a study by showing, I forgot his name now, Curtis Suttle, showing that viruses fall from the sky. He put pails up in mountains in Spain, and they left them there. And viruses fall from the sky, and he thinks that they're whipped up in the oceans by the wind, and they go up very high, and then they travel in the winds, and then they fall elsewhere. Because he actually determined where they were from. He could tell they were ocean viruses up in the mountains in Spain. So, yeah, they could happen.
Those were phage, right?
Yeah, those are phage or viruses of protozoans in the ocean or something like that, yeah.
So that it would have to get in the ocean first?
Well, that's what he found, but because he thinks the wind whips up. But I think also the winds over deserts can whip up whatever's in the sand and bring that around. I think it's probably unlikely, although no one's looked. But as Rich said, it's more likely that travel. It's the least, it's the lowest energy barrier to this happening, I think. But tell us if someone knows something. I thought if Alan were here, he would talk about the jet stream because he likes that.
I encourage anybody to have a look at this app called Flight Radar 24 to look and see how many airplanes are in the air at any given time. Globally, and it's just astonishing.
So I remember we discussed a paper, discussed being just posting things on Slack about it. That was April 4th, describing how many people had traveled to China since the virus surfaced, and there were 1,300 direct flights to 17 cities before the travel restrictions. And the highest number, as I recall, was to Los Angeles. So I'm still surprised that things appeared in Washington State before LA, but I think jet's more likely than the jet stream.
I don't know if Wuhan is positioned to put viruses. I don't know how they would get up, right? Because in the oceans, they're whipped up by winds in the deserts, but Wuhan.
Yeah, that would be the hardest part. Well, that and the length of time the virus would have to be in the aerosol.
Yeah. All right. This next one is from Tom. Hello, Twivers. I live in Astoria, Oregon. I'm on the city council here. Oregon's Governor Kate Brown plans on initiating statewide random sample surveillance of 100,000 volunteers. As I understand it, this 100,000 volunteers will be tracked over the next year. Another subset will be a 10,000 who will be tested for COVID-19. Letters going out to Oregonians on May 11th, and it sends a link to this program. Strikes me it's a great opportunity. What do you think? New to your program, I'm glad to have found you and found it extraordinarily informative. Tom, I think this is a great idea.
Mm-hmm.
I wish they could do more. I mean, 10,000 is not a lot, right? I mean, if you get the right 10,000 distributed in the right way, then you can make some inferences. But it's a good start. And so these people are going to be selected at random to represent, different kinds of people in the state. And then you're going to have your temperature monitored, other symptoms every day for 12 months, using things that are smart and will broadcast your data. If you have a symptom, you get a home test kit. Will enable them to detect the virus at its earlier stage. So I don't know how that's going to work. You're going to probably have to send it somewhere for PCR.
Right.
And then you get a follow-up. And 10,000 people are going to get test kits right away to provide data about symptom-free infections. That's interesting. I wish we could do that for 100,000 people. And in many centers throughout the country, rural and urban centers would be very interesting, right? So you could compare what's going on and start that now and continue through the summer. I mean, the government could pay for all of that. They could take an initiative and pay for kits, send them, coordinate this kind of study. It's great that states are doing it. But in my opinion, it should be a federally done thing. The CDC should be running it and paying for it.
And that would really help the models like Rich mentioned. And that would really help our understanding of whether or not to open universities and all sorts of other questions that people have.
Yeah, It would be good. But so anyway, Tom, good idea. And you should do more.
And thanks for the information. That's we'll be looking for that.
Kathy.
Daniel writes, Dear TWiVers, I'm a pediatric infectious disease specialist from Taiwan, and I've been listening to TWiV since episode 100. I really want to thank you wholeheartedly for the great podcast. I always enjoy listening and absolutely learn a lot from it. This is my first time writing to TWiV, and I would like to share with you some Taiwan experiences on the management of COVID-19 pandemic. Taiwan has a population of 23 million people, and until May 4th, we have 437 confirmed cases, including only 55 local cases and 6 deaths. We have tested more than 60,000 high-risk people in the past 100 days, leading to a positive test ratio of about 1 positive case out of 150 tests. As you can see from what is going on in the world now, an effective prevention of the epidemic cannot be done by government enforcement alone. It has to be a collaboration between the government and the people. And I must say, Taiwan has set a superb example of risk communication this time. In the past 100 days, Taiwan CDC has been hosting press conferences every day at 2 p.m. to report the most updated COVID-19 cases and information, providing Q&A sessions, and most importantly, everyone can see it live on TV or on the internet. And I believe this simple action is a key for the government of Taiwan to build trust with its people. Taiwan CDC's strategy set many examples to let its people feel secure and safe. For example, we started border control in advance. In fact, Taiwan is probably the first country that started border control and management ahead of the world. Taiwan CDC also practices thorough and complete test, trace, isolate from the beginning. Since early February, anyone traveling from China or anyone who has contacts with COVID-19 patients must practice a 14-day home quarantine. In March, the quarantine requirement broadened, so everyone who entered Taiwan needs to be home quarantined for 14 days. Nonetheless, in my opinion, I believe a key strategy that is only being practiced in Taiwan is the mask production management. In January 2020, Taiwan's mask production was only about 1.8 million pieces per day, and we have a population of 23 million people in Taiwan. So the government worked with the local factories providing help, increased mask production lines immediately, and took control over the masks so that there is no scarcity over the lack of masks, and more importantly, the price of masks are stable as in the past. Right now, Taiwan can produce 16 million masks daily, and the number is still increasing. People are wearing masks whenever we go outside, plus frequent use of hand sanitizers. We don't have to have very strict social distancing, and people in Taiwan can almost maintain the same lifestyle as we all used to have, with very low and limited community spread of the virus. So, unlike other places in the world, Taiwan did not have a lockdown. We still go to work, and students still attend schools normally. All the businesses were operating as usual. The only restriction is that of mass gathering. I must say people in Taiwan eliminated a lot of social gathering and practice work from home voluntarily. There is no need for government enforcement. By the way, our professional baseball just started this season as scheduled, though there were no on-site audiences. All the games were streamed live for the baseball fans. During SARS in 2003, we locked down a hospital. That was a bitter experience. We realized that lockdown is the last option, and it impacted negatively in many ways to the society. In order to prevent the same thing happening, the government must work well with people. And on top of that, the most important factor is early decisiveness on prevention. We must act ahead and plan ahead for the worst. So in my opinion, the three most important lessons Taiwan can provide to the world in handling COVID-19 are advanced decisiveness, scientific thinking, and an effective risk communication. I really hope our experience could offer some help for countries around the world to maintain low transmission of SARS-CoV-2 after reopening of society. Best regards, Daniel.
Excellent.
Yeah.
That's great. That's really
to me. This speaks to the previous letter about opening schools, because I think that there are a lot of fairly simple things that can be done that limit the spread, even in the context of people getting together and going to school and going to work and that kind of stuff, like masks, like hand sanitizer, just a lot of common sense measures.
For sure. I think we should hear more about this, and we've been talking about this, right? It's possible to limit spread if you do these things. Masks are great, but I still don't see a lot of people wearing them.
Well, yeah, I'm not sure if he's talking about surgical masks or something even more than that, but probably surgical. Yeah.
And, the thing is, as states start to talk about reopening, then people get more and more lax. And I went to pick up my son's stuff from Marist last weekend, a weekend before. Gosh, I don't even remember. Time is merging. But as we got further and further north, his school is in Poughkeepsie. I mean, the parking lots of shopping centers were full. People are just walking. Restaurants were open. People were canoeing. Nobody had masks on. Now, the transmission is much lower up there, but wow.
But even so, just wearing masks is a really simple thing you can do, and it would be very helpful.
Yeah. Wear a mask. The Condit used to say, wash your hands. Wear a mask, too.
Actually, this is another area where certainly my thinking has evolved. I think a lot of thinking has evolved, because early on in this, we sort of poo-pooed the idea of masks. And there was a lot of controversy about whether or not there was any effectiveness, and that the thinking on that has changed. And it's not a hard thing to do.
No, I was going by CDC recommendations, who said don't wear them, and then they changed their mind. I wish we had a CDC like the Taiwan, where they do the press conference. I mean, the CDC should be doing the press conference every day, right? Not politicians. I'm sorry, Brianne.
No, I was going to say I've also kind of had a little bit of a change of heart here. And I think this is one of those things where when you see the data, if you're a scientist, you can change your mind.
Sure. Yeah. Sure. You have to. Otherwise, you're not going to be a scientist if you don't change your mind.
So it's all about, taking in new data and making new conclusions based on that. And so now I wear a mask all the time.
Okay, Brianne, you're next. Zach?
But before we do that, I was just going to say I didn't have time to research this extensively, but there's an article in Outside magazine suggesting that runners and cyclists, or they're talking about a paper that came out before that, so it's not in Outside itself. Cyclists and runners need much more than 6 feet. The report went viral and backlash ensued, but it says there's some legitimate science about it. So I don't know if anybody's looked into that, but it's something like saying that for bicyclists it should be 65 feet, and for runners it should be 15 to 30 feet.
I think I saw the same article with illustrations that made it look like a cyclist or a runner has almost like a comet tail of virus
This is
streaming behind them.
Oh yeah, I see that figure now. Yeah,
but they're not wearing face masks, right?
Right.
I'm going to, actually, I'm interested in your comment on this, Kathy. I'm going to attend a webinar this afternoon put on by the Barbershop Harmony Society to try and advise its chorus chapters what to do emerging from this. Okay. Ordinarily, you got, for our chorus, maybe 25, maybe 30 people standing right next to each other on the risers, exhaling on each other. So now what? I don't know. I'll be interested to see this webinar. We have a we have a you probably do this as well. Bubbling notes for air control, for breath control and stuff, where you bubble your lips like.
We don't call it that, but yeah. Okay. Lip trills. Yeah.
Lip drills. Okay. We're not doing that.
I forgot who's next. Brianne?
Yeah. Yes. Zach writes, "Hello all. While listening to TWiV 609 and Susan Weiss talking about SARS and MERS, I came to a simple question. Why is MERS not considered a SARS-like coronavirus? I heard you all refer to bat or animal isolates as either SARS-like or MERS-like. So is it the active host receptors, the pathogenesis, or genomes that determine whether or not an animal coronavirus is considered SARS-like or MERS-like? Thanks again for everything each of you do. P.S. Professor Racaniello, in light of this pandemic, have you considered devoting an entire lecture to coronaviruses in your virology class like you have for Ebola, HIV, and H5N1? Or are there still too many unknowns about coronaviruses as a whole to give an entire lecture on them?"
Well, Zach has listened to many years because we haven't had a Ebola and H5 lecture for a couple of years now. So the SARS-like is the genome, right? That's it.
Yeah.
And that's
I think they happen to use similar host receptors, but it's based on the genome.
Yeah.
Right.
The SARS viruses, the MERS, of course, is a different receptor, right?
Right.
DPP4. But yeah, I think Ralph said that that's the definition of a SARS-like corona. It's in the family of viruses in bats in China, mainly, or only. So it's not but bats have coronas elsewhere, but they're not SARS-like. But it's the genome dictates everything. Everything flows from the genome, right?
Right. So it's sort of where they fall on that evolutionary tree in terms of their genome, or where their genome falls.
Yeah. I don't know. I could do a lecture next year. We'll see. There's already a lot of stuff. You could definitely fill a whole lecture with it would be a lot of questions. It could be quite interesting. But, I give one virus-centric lecture. It's mainly been HIV, because there's so much there, but yeah, one could change it or add to it there. We'll see, Zach. We'll see. It's a good idea.
Do you give a lecture like on pandemics or?
I have emerging viruses,
yeah.
and that deals a lot with it. And then we have an ecology, which has a little bit of that too. Yeah. We touch on pandemics throughout many different lectures. Yeah.
Yeah, the only one where I do a lot of virus-specific lectures is in my emerging infectious disease class. So there I have a coronavirus lecture, but not specifically in my virology class.
Yeah. Rich, you're next.
You're going to have to help me translate this, I think. Many thanks for the wonderful program. Going back to the oral polio vaccine, if that does work the wonder, my question is then, will getting coronavirus caused common cold do the same trick? So I think
he's asking if you got the common cold coronavirus
from a coronavirus,
would that protect you?
Right. So the idea behind the oral polio vaccine, right, is sort of the same idea of BCG, right? You're sort of a generalized stimulation of innate immunity,
right?
I don't know. I suppose you could get the same effect from almost any kind of infection, depending on how robust an innate immune response you get from that.
Right. I think that innate immunity phenomenon is based on this thing known as trained immunity, and I don't think we know quite enough about that to really be able to say. I don't think we know a whole lot about it. At least I don't, but that's more because it was largely discovered after I finished graduate school.
So if you get influenza, right, like now, you get a bout of really good influenza and then you recover, are you going to have some general trained innate immunity that'll protect you from SARS-CoV-2?
I mean, I think the idea, I don't know.
Yes, I mean, it's possible, right?
I guess it is possible. I don't think that it's been examined with influenza particularly well. It seems like there are certain pathogens that induce this immunity particularly well, but I don't know that we understand it all that well.
I mean, Kostya Chumakov, who talked about this OPV idea, he said other vaccines would probably have a similar effect, like measles and shingles vaccine. So it could be that some natural infections do it too. Although my impression of these common cold coronas, you get reinfected quite often, and I'm not sure that that's a good one to bank on. But it's a good question.
We don't think that any sort of co-infection would necessarily be helpful.
No, not but if you have one, would you then recover from it and then be, have this protection for a couple of months against something else? I mean, that's a thing you could probe epidemiologically, right? Mm-hmm. Rich, you're next.
Margaret writes, Dear Houston, we have a problem. My sisters, very well-educated people, were with me on our daily 9:00 Zoom call with my parents who are stuck in an assisted living facility where there is no COVID, thank God. And what should they start to talk about but the Wuhan bioterrorism conspiracy theory? I thought they were too well-educated to fall for that bunk. I found myself at a loss to dispel their nonsense. But I found myself falling back on, quote, but a very important group of virologists from Columbia, the University of Michigan, and other very important places said that it was not true, end quote. In fact, to my chagrin, this explanation sounds equally ignorant as their conspiracy. I need talking points in plain English. Could you please dumb down the answers to these questions? 1, how do you know SARS-CoV-2 is not man-made or genetically altered? As a benchmark for how dumb, here's what I said to them. The virologist can look at the genome and tell it was not modified by humans because they can tell by looking at it. Follow-up question, really? How? Me, I don't know. The virologist said so.
but
I don't know.
Right.
They said, this is great.
Yeah.
She's right, yeah. But I love this. She says, I don't know. They said words I couldn't understand. And I don't have time right now to, 1, go back and find a place where they answered this in a podcast, and 2, look up all the words and study enough biology to understand what they said in enough detail to teach it to you now, but I'll look it up and get back to you. 2, how do you know SARS-CoV-2 is not mutating into different strains the way flu does? I'll skip her stuff on that just for the sake of time, but she's very entertaining. Look, I'm exaggerating this a tiny bit for comic effect, but this is what's going on. Intelligent people, in light of not having comprehensible scientific explanations, are latching onto conspiracy theories. What do I do? This quote from The Atlantic puts it very well. This is the Ed Yong article, which is absolutely outstanding. Journalists still think of their job. Oh, this is wonderful. This is Ed Yong, right?
Mm-hmm.
God. As a matter of fact,
Ed
after
Yong quoting someone else.
Okay. But still, after reading his article, I finally downloaded. What is it? The multitudes within us.
I make all of my microbiology students read it.
Quote, journalists still think of their job as producing new content, but if your goal is public understanding of COVID-19, one piece of new content after another doesn't get you there. It requires a lot of background knowledge to understand the updates, and the news system is terrible at providing that knowledge. Instead, the staccato pulse of reports merely amplifies the wobbliness of the scientific process, turns incremental bits of evidence into game changers, and intensifies the already palpable sense of uncertainty that drives people towards misinformation. Beautiful. This is what you're up against, Houston.
I didn't really get that. Uncertainty drives them towards misinformation. That's just horrible, isn't it?
Yeah.
Because I mean, I understand that. I try and keep it very simple, not even tell them why you can look at the genome and tell it. I mean, if you want to really know how, we need more time and more detail. And I'm afraid that not everyone will have it. That's why we try and keep it simple, right? But let me try. Let me try, and then you can try. So,
and maybe we can make sure that Jolene timestamps this for the plain English explanations.
Jolene, wake up.
She'll get it.
The first question, how do we
go back
know,
a little bit?
How do we know it's not man-made or human-made or genetically engineered? So, first of all, you would have to have something to start with to engineer. You would have to have a virus that's very close to the one SARS-CoV-2 that's in us. And as far as we know, from all the papers that have been published and all the genomes that are in the databases that are accessible, there's nothing close to it except this bat isolate from 2013, which is not really close enough to be the one that they modified and released in us. So that's the main thing. So nobody took a virus that did not infect people and modify it to become SARS-CoV-2, first because they wouldn't know how to do that, and second because there's nothing close enough that would have been the precursor, and they wouldn't know what to do. There's just no way they would know to put some of the changes in this virus that make it able to transmit really well among people. I know it doesn't explain it, but...
let me try and be devil's advocate. Well, aren't scientists really good at doing this kind of engineering? Couldn't they make such a virus?
No, they're not good at making viruses that infect people. They're good at making other kinds of viruses in the lab that infect mice or don't infect mice and so forth. But no one's made a virus that can infect people.
One could, given some sequence or other, say the bat virus that's most closely related to this, one could actually technically, it would be difficult because there's a lot of differences, but one could actually technically make the changes. And as a matter of fact, you could synthesize this virus from scratch, just from chemically, okay? But you wouldn't know what to make. No one would think of making a virus that had this sequence.
And it's not just that if you look at, so you can look at the bat virus from 2013 and you can look at the SARS-CoV-2 virus and make some comparisons. And you do see some parts that are different in, say, the receptor binding site or in the furin cleavage site that we now say, aha, that we think is causing some part of what we're seeing in this COVID-19 epidemic. But you also see a lot of other kind of random changes here and there that may not make much of a change in the virus structure itself. They're just sort of random changes in the RNA that have been picked up over time. Mm-hmm. And so even if we knew that you should put in a furin cleavage site or one of those important sites, you wouldn't put in all of the random kind of mistakes in the RNA or all of the random just changes in the RNA that don't seem to have any particular effect. You wouldn't put those in for any particular reason. And it's hard to imagine how all of those random changes would have been picked up if this was being made in a lab. And so I think that to me, seeing all of those things, which are sort of like the random mutations or the genetic drift, that would be something you would see if the virus was evolving in nature, but would not necessarily be something you would see if the virus was in a lab, to me is the biggest piece of evidence.
So there are two things that Brianne mentioned. The furin cleavage site, it's a sequence in the spike protein that is cleaved by a cell protease, and that's not in the bat virus. And so a lot of people say, look, they put in a furin site to make it pathogenic for people. How would you know to do that? You would have no idea, first of all. And second, apparently now there are results suggesting that you could take it out and it doesn't matter for the virus to reproduce in human cells. And so I think the furin site as a tensional insertion is just off the base. And the other part she mentioned is receptor binding domain. The bat virus and the human are slightly different. So then they found this virus in pangolins where the receptor binding domain is the same in the pangolin isolate in humans, but the rest of the genome is not. So you have bits and pieces all over here. No one would have known to combine them all into this virus. So that's the thing. Nobody's that brilliant to do that. And that's not a great answer, but,
no. One of my, I know someone who sort of likes to play devil's advocate from time to time, who was arguing this with me, and he said, well, what if you did? What if someone did know that you wanted to put those in, and you wanted to put in some natural mutation to hide what you were doing? And I don't think anyone would have put in that many natural mutations. I mean, if it were me, I'm too lazy for that.
But the bottom line is you don't even have to use that argument because, I lost my thread. Somebody else talk while I try and get it.
So, one of the things I was thinking is that correct me if I'm wrong here, but some of the changes in the receptor binding domain in this virus that, according to structural analysis, make it adaptable, make it so that it will bind the human receptor, are changes that if scientists looked at it, they go, whoa, you mean that can do it?
Yeah,
okay.
That's right.
It's that unanticipated.
Yeah. So then the devil advocate would say, well, maybe there was a smart person who chanced on it. And then I would say, you're getting to the point where you're just making accusations and you're not basing them on data.
Right.
Everything we have said so far is based on the sequence. And if you say, well, maybe they had it, that's an accusation for which you have zero support. Right. And that's what really the bottom line is here. We have lots of information about why this was made in nature. And all you have is, yeah, but they could have. Yeah, but they could have. That's not information. That's not data.
Right. So there's a couple of other scenarios that I've thought of, and that is that you could take one might argue that you could take something like the bat virus and passage it somehow in the laboratory to select for something that was transmissible in humans, and that doesn't make any sense to me. I think that in order to get something that was really transmissible in humans based on what we know, you'd have to passage it in humans. Okay.
Yeah, bat virus is still too different from SARS-CoV-2 to do that. You wouldn't get that many changes.
Yeah, you can't in a laboratory situation apply an appropriate selection to come up with a virus that's going to work this well in nature. As we've said many times before, Mother Nature is much, much, much better at this than we are. So what you're left with is, as you were talking about, Vincent, some sort of really conspiracy theory that said, well, they must have gotten this virus from somewhere, okay, that nobody's ever, that's in secret, right? Well, forget it, okay? It doesn't make any sense.
Well, that's a kind of argument you can't counter because they say, well, what if this or that? Well, there's no evidence for it. And by the way, what Rich just said, this bat virus, that they passed it in the lab, the bat virus was isolated in 2013. So this is 6 years of mutations. You could never do that. You'd have to pass it for 10 years in the laboratory to get that. And I don't think anyone did that.
Right. Well, I think the other thing to remember is that this 2013 virus that we're talking about is a virus that was isolated from doing some natural sampling of bats in a cave in China. Just like we had earlier talked about the rodent coronavirus sampling in nature. And in that study, they got samples from this cave and then looked for different coronaviruses that to that point had never previously been discovered. That should be information that tells us that there are lots of coronaviruses and other viruses that we don't currently know about. And we only know a small fraction of them. And so it's quite likely that there are other coronaviruses that we don't know about that could be coming out of bats or other animals like this one seems to have done. Given how frequently, when we look at these natural sources, how frequently we find new viruses, this seems like a very plausible thing that happens frequently.
And that's exactly the work that needs to be done, which was the money for that was withdrawn recently from EcoHealth Alliance.
Yeah.
Because they said they were supporting the Wuhan lab when, in fact, they were just supporting sampling in China, which is what we need to predict the next pandemic. So suspending that funding was crazy. It doesn't make
one of the things that really annoys me is that we have individuals in responsible positions in the administration, and I'm thinking here of the one that I saw most recently, which is Mike Pompeo, promulgating this idea. And I can't remember the exact words he used, something like that there's a possibility or something like that. It was very cleverly worded, but talking about the possibility that this came from the Wuhan laboratory. And one of the problems here is that scientists always qualify everything they say. They're unwilling to say absolutely yes or no. In this case, I would say absolutely no. But so that the way scientists word things, somebody can get a hold of that and say, well, you could probably create a talking point here and back it up with some credible virologist saying you can't, that you could if you knew how build the sequence. It's technically possible, okay? And spin that into a conspiracy theory. But the very fact that people in responsible positions are actually doing this doesn't help at all. And it's pointless. It's pointless.
Pompeo said they had good evidence, but there is no good evidence.
So I've been a little bit quiet here because I've been looking for two things. And one of them I've already pasted into the show notes. It's something that I haven't looked at in detail that I just saw today in the National Geographic. The title of the article is Dr. Fauci Doesn't Entertain Theory That Coronavirus Escaped from Chinese Lab. So it may be that Margaret's parents are with the majority of people who find Dr. Fauci very credible, and that could be some evidence that puts them a little more into the believing side. And I haven't looked at it to see in detail if he elaborates as to why. But I know that there was an earlier National Geographic article that I supplied for our curated web page for our department that describes this. And it turns out that web link is broken. So I'll get that fixed, and we can perhaps put that link in the show notes as well, about a nice sort of layperson type of article as to why the conspiracy theories just don't hold up. I mean, if you want to think that the Earth is flat or that we did not land on the moon, then you're going to probably go with this conspiracy theory. But there's a lot of evidence that suggests that it did not escape from a lab. It was not genetically engineered.
I would go further than that, Kathy. I would say, if you're going to go with that, you're wrong.
Yeah.
This is how we get ourselves in trouble. There is a lot of evidence that it didn't happen, right? We're trained to be wrong.
Yeah. Well, there's zero evidence that it came from a lab. Zero, right?
Right.
And a lot more evidence that it came from nature. That's the bottom line here. And just saying they
very
might have
well that it's natural.
Yeah. Let's finally do. How do you know SARS-CoV-2 is not mutating into different strains the way flu does? It's not, because a strain is a virus with a different biological property, not just a different genetic sequence. And, we have different isolates of SARS-CoV-2. They have different sequences, but they're all the same in their properties. And it's not changing the way they're reacting with defense proteins, antibodies. So how do we know? Because from our history of studying coronaviruses, we know they do not mutate the way that influenza viruses do. And I'm confident that SARS-CoV-2 is behaving just like those other coronaviruses. They are all what we say antigenically stable. They don't change like influenza virus does. How do we know? Because we can look at their genomes, and it tells us.
And we can take different versions and test them in cells and show that they have the same properties.
So to put it another way, RNA viruses mutate. Influenza is an RNA virus, it mutates. Coronavirus is an RNA virus, it mutates. They do both mutate, but the mutation that's happening in the influenza virus is changing the antigenic properties of it so that we have different influenza viruses each year that we need to make new vaccines to. The coronavirus mutations are not changing the surface proteins that the antibodies react with. And so we know that it is mutating, but it's not mutating in the same kind of way that influenza virus is.
There's another thing about this letter that interests me, and that is that her response to a lot of these questions to her parents falls back on the virologists said so. Okay. And, we do this as well. I mean, you can't, I have not demonstrated to myself that atomic theory is correct. I've trusted other scientists. And so we have to have some faith that these well-established scientific principles hold up. And unfortunately, we're in a situation where there are people who are willing to trust when there's a difference of opinion, trust a politician or a conspiracy theorist rather than the scientists. And all I can say about that is that it's unfortunate. And I would go back. Dixon often says, don't trust scientists, trust the science. Because over time, again and again and again, it is self-correcting and verifiable. So I think that I would hope that saying the virologist said so, in fact, is a credible argument.
Yeah, otherwise you have to get a lot of detail. And I'm afraid what we just did may not be good enough. She wanted something, plain English, talking points. We didn't do it. Sorry, but maybe you can condense it down.
I think that Ed Yong article, does it address this conspiracy theory?
The most recent Ed Yong one? I don't
the one at the Atlantic about why the coronavirus is so confusing?
I don't think this one does, but he has written quite a few of them recently, and they're pretty much all wonderful. And I think there are some that do address it.
The coronavirus is confusing because as that quote says from the Atlantic.
It's right here. I found where he does discuss it a bit.
Coronaviruses are confusing because you can't learn about them from journalists because they just want to make new content. As that quote says, if you want to learn about the virus, learn it from scientists. And what better place than TWiV? And if it's too long, don't complain. I'm sorry, we're doing our best. Takes a long time to explain this. I'm not getting mad. I'm not grumpy or anything. Just saying, if you want an explanation, you have to be patient. You can't expect it in 30 seconds.
Right.
Yes.
The press does not help this. Okay. So last night I was watching the PBS NewsHour. I mean, this is public television, right? And they had a section, a segment where essentially the headline was that they were going to talk about this idea that the virus came from the Wuhan lab. And they interviewed two experts, which were, I forget, they were people from think tanks or campaigns that, represented politically actually motivated diverse opinions, or at least diverse opinions on this whole thing. And the interesting thing is that there was nothing in the interviews or the report itself that said anything about this virus coming from the Wuhan lab. It said more about whether or not China should bear some responsibility for our understanding of the status of the virus or delays in reporting it or whatever. Nothing about the Wuhan lab. And yet that was their headline. Okay, so the journalists are just as problematic in some cases as others, politicians and other people.
I just wanted to, before we stop, Norman had sent in a way that you can go to YouTube and get transcripts, computer-generated transcripts of TWiV. I've been posting TWiV on YouTube lately as an audio-only file, but it turns out that YouTube has a built-in translator. It's called closed caption. So there's a button called closed caption, and you get text that crawls across the bottom of the screen. But you can also get that apparently in one big file, and he puts the instructions there, and you can see the whole thing and copy it and paste it somewhere else. Now, it's a computer-generated file, so it does have mistakes. So, for example, in last week's episode, he pasted in a few lines of the computer-generated transcript where it says, let's see, this is episode 609, recorded on May 1st. I'm Vincent Rockin' Yellow. Joining me today from Fort Lee, New Jersey, Dixon Depot. Okay, so if you can deal with that, you can have a transcript over at YouTube.
I would be careful when you get further into the more technical things. I know that some of my students have done these same types of transcripts of some of my immunology lectures. And when you get into the sort of scientific terminology, it gets rather interesting and not very close to what you said.
Yes. All right. That is TWiV 610, a special midweek edition. I just want to mention that today there's breaking news about mutations in the SARS-CoV-2 genome. Everyone's going nuts about this, and we're going to do a TWiVo right next with Nels Elde, and he's going to talk about this. So that should be up sometime in the next few days.
So that's Kathy, This Week in Evolution, also available at Microbe TV.
And did you want to say something else, Kathy?
No, that's all I wanted to say.
Oh, that was you. That was your pre-pick.
Right.
Got it. Okay.
It hasn't been recorded yet, but I expect it will be good.
I hope so. Nels is always good. These show notes and the letters and everything, you can find them at microbe.tv/TWiV. Questions and comments, TWiV at microbe.tv. If you like what we do, consider supporting us, microbe.tv/contribute. Kathy Spindler's at the University of Michigan, Ann Arbor, Michigan. Thank you, Kathy.
Thanks. This is a lot of fun.
Brianne Barker's over at Drew University on Twitter, BioProf Barker. Thank you, Brianne.
Thanks. It was great to be here.
Rich Condit is an emeritus professor. I should just say Rich Condit is retired.
Oh,
emeritus professor.
That's going to need some explanation now.
Right.
Well, there is a preprint. What is it? BioArchive?
MedArchive.
MedArchive by someone named Richard Condit, which is not our Rich Condit here. And if has an asterisk on the name, and at the bottom it says retired with no institutional affiliation. So that's why it's funny, because I usually say Rich Condit is an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, always a good time. And I have to say, it's a privilege to be able to participate in this. I appreciate it.
It's great having all of you. I really appreciate your time. And I think this is a good time for all of us to be explaining science to people. So I do thank everyone. I'm Vincent Racaniello. You can find me at virology.blog. I want to thank the American Society for Virology and the American Society for Microbiology. Those are two professional societies for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.